Welcome to the RSNA RadioGraphics podcast. I am Dr. Refky Nicola hosting today's podcast from SUNY Upstate Medical University. And today, in honor of Black History Month, I will be discussing the topic of health disparities, especially among Black patients, as well as anti-Black discrimination among Black physicians within the medical and radiological societies in the late 19th century. This discussion is based upon an article written by Dr. Julia Goldberg, who is a third-year radiology resident from NYU Langone Medical Center, entitled How We Got Here, the Legacy of Anti-Black Discrimination in Radiology, which details the historical aspect of this topic. I'm joined today by Dr. Goldberg herself, who is the first author to discuss the article. Welcome to the podcast, Dr. Goldberg. Tell us, what inspired you to write this article and what were your references?
I also majored in anthropology in college, and I find it so important to examine the reasons why we see the disparities we see today, understanding history and cultural contributions, along with healthcare structures that create barriers to care. I discussed this idea with my mentor, Dr. Nicole Heineman, and we developed this project to document specifically anti-Black racism we see today in the field and to understand its history, from both the patient and the provider side. We looked at research that encompasses the history of radiology, of medicine, health disparities in radiology, and professional diversity in our field. Dr. Alan Oestreich was one of the first to begin documenting the history of Black radiologists in the 1990s. And more recently, there's been a greater focus on examining health disparities we see in radiology. JACR published a special issue on health equity in 2019, and so many other authors have focused on these important issues in recent years, which made it possible to include so much evidence for radiology-related healthcare disparities and race-based discrimination in our paper.
In the article, the history of anti-Black discrimination in medical education occurred as early as 1850, when three Black applicants to medical schools were Daniel Langone, Martin Delaney, and Isaac Snowden, who were accepted into Harvard Medical School, were subsequently expelled because of a petition which was signed by a quarter of the white medical students protesting their presence on campus. This eventually led to the establishment of Howard University College of Medicine, as well as 6 other medical schools. However, they did not survive because of a report by Dr. Abraham Flexner, which resulted in 5 out of 7 schools being closed. This left only 4 historically Black medical schools in operation. Can you tell us some of the structural discriminations within the early medical societies, such as the AMA, RSNA, and the ABR?
The culture of each of these medical societies really reflected that of American society at the time. Now, the AMA was established in 1847 when slavery was widespread in southern states, and early on engaged with scientific racism. For example, in 1850, an AMA committee falsely reported a smaller size of brains from individuals from Africa compared to those from Europe. Now, regarding physician membership, Black membership was in effect only allowed in northern states. The AMA specifically excluded a racially integrated society from Washington, D.C. in 1870, and 2 years later decided to only recognize delegations sent from state societies, many of which specifically excluded Black physicians. Even as late as the 1950s, the Louisiana State Medical Society and others specifically excluded Black physicians from membership, which the AMA allowed through the early civil rights movement. The RSNA was established in 1915 and required 2 current members to sponsor a new applicant, all of whom were non-Black for the first 20 years of its existence. This created large barriers to admission, as Dr. William Edward Allen Jr. was rejected in 1934, even after publishing widely in major radiology journals. He was accepted for membership only after Dr. Lawrence D. Scott, the first known Black member of the RSNA, subsequently sponsored Dr. Allen's admission application. And the ABR was established in 1934 and required membership in the RSNA or the ARRS, both of which initially had no Black members, or the Canadian Medical Association or the AMA, which excluded Black physicians in southern and border states. The first Black member to be certified by the ABR was Dr. Allen, who was actually forced to take the freight elevator to the exam because of his race, while white applicants were allowed to take the hotel's guest elevator. Now, as a result of this discrimination from medical societies, Black physicians established the NMA, the National Medical Association, in 1895 to establish a professional space to engage in research and medical leadership that was otherwise not available to them through these other medical societies.
Who are the pioneer Black radiologists and how did they help advance the field of radiology?
So, since the early development of imaging as a clinical specialty, there have been Black radiologists engaging in research and patient care to advance the fields of radiology. Dr. Marcus F. Wheatland is recognized as the first Black radiologist who worked as a physician in Newport, Rhode Island, and started using X-rays in his medical practice in 1902. He engaged in extensive scholarly work, publishing on the use of X-rays in multiple journals, including in JAMA in 1905. He was also very active in the NMA, serving as president in 1910, and he delivered NMA's first lecture in radiology. Dr. William E. Allen Jr. was the first Black member certified by the ABR in 1935, the first Black member of the ACR in 1940. He was the second known Black member of the RSNA in 1948, and he was very active in the NMA, founding and chairing its section on radiology in 1949. He widely engaged in radiology research and published articles in many esteemed medical journals, including in Radiology and the AJR. Dr. Allen worked to expand access to the professional fields of radiology, creating training programs and scholarships for Black radiology students in the 1930s. He became the first Black member to receive ACR's highest honor, the Gold Medal Award. Dr. Claudius DeWitt Bell and Dr. Lawrence Disraeli Scott also published on X-rays in the early 20th century, and there were so many other pioneering Black radiologists that advanced the fields of radiology in different ways, including through research, leadership in professional societies, radiology departments, and hospitals. And I would really encourage you to read our paper to learn more about this history.
Still today, Black physicians are significantly underrepresented in the radiology workforce. They comprise of only 6.2% of medical school graduates, 3.1% of diagnostic radiology residents, and 2.1% of practicing radiology physicians, and 2% of radiology faculty. Radiology currently ranks 18th for Black physicians representation across all medical specialties, despite being 9th for specialty size. Can you tell us some of the health disparities in cancer imaging as well as other imaging in other areas? Can you give us some statistics based upon your article?
Sure. So, looking specifically at oncologic care, there are imaging-based screening guidelines for breast cancer, lung cancer, and colorectal cancer, all of which demonstrate race-based healthcare disparities. So, in breast cancer, there's an approximately 40% higher mortality rate among Black women compared to white women. Imaging accessibility may serve as a major factor. There are decreased rates of screening mammography and screening MRI for the Black female patient population, and it's been well documented that breast imaging facilities with higher proportions of non-white patients have longer delays for biopsy workup, longer wait times, and fewer radiologists. Black women have on average longer travel times to access breast MRI examinations, and there have been lower rates of adoption of digital breast tomosynthesis in geographic areas with higher Black patient populations. There's also approximately a 25% higher mortality rate from lung cancer for the Black patient population, for which there is earlier disease onset and more advanced stage at lung cancer diagnosis, even when accounting for smoking history. Even so, there have been lower rates of lung cancer screening for Black patients, in part because of the screening algorithms used. One study found that the majority of Black smokers with lung cancer were initially not eligible for screening, whereas the majority of white smokers were eligible. There were reasonable concerns that screening guidelines did not adequately address the risk of lung cancer for Black patients. And about 2 years ago, the USPSTF actually expanded lung cancer screening guidelines, in part to address the screening eligibility disparity. Looking at colorectal cancer, there is an approximately 20% higher cancer incidence in the Black patient population and a 40% higher mortality rate from colorectal cancer. Racial disparities have also been seen with the use of PET-CT for evaluation of non-small cell lung cancer, the use of multiparametric MRI for prostate cancer, and in procedural interventions with the use of mechanical thrombectomy for the treatment of stroke. Looking at the field as a whole, it has been shown that there is decreased use of imaging in both pediatric and adult emergency departments for Black patients compared with white patients. And we see the ways in which access to imaging is limited and ways in which current imaging screening guidelines may not adequately address disparities in patient outcomes seen today.
In your article, what did you propose as potential solutions to address healthcare disparities and anti-Black bias in the field of radiology?
Yeah, so there are so many ways to address healthcare disparities and engage in anti-racism work in radiology. The first step is really education, learning about the current status of healthcare disparities and differential access to imaging and cancer screening. From there, we can address potential barriers to access, which are really multifactorial, including issues like limited insurance coverage, cancer screening algorithms, and increased distance to radiology facilities, especially ones with newer technological innovations. Looking at technology, artificial intelligence is trained on current healthcare data, which has race-based healthcare disparities. So it's crucial to develop anti-bias methodology to ensure these disparities aren't propagated further through the use of AI. Technology could also be used to counter bias from referring providers, for example, by providing EMR evidence-based guidelines for ordering imaging studies. Within the professional environment, expanding diversity is crucial for both our own radiologist community and for patients alike. Increased diversity in the professional workforce has been tied to overall performance improvement and innovative practices, and is also associated with increased professional efforts to challenge racial barriers to care, which ultimately improves patient outcomes. There are now multiple opportunities to get involved with anti-racism and social justice radiology efforts through the ACR and AMA, and in advocacy through other local and national social justice organizations. And the responsibility for health equity is not limited to primary care or to referring physicians, but rather relates to everyone in the professional radiology community. Radiology is a central piece of the provision of healthcare today, and ensuring equitable access to and engagement with imaging will improve patient healthcare outcomes.
Thank you so much, Dr. Goldberg, for joining us. Radiology is truly indebted to all the pioneer Black radiologists, from Dr. William Edward Allen, who was the first Black member certified by the ABR, to Dr. Marcus Whitland, who started using X-rays in his medical practice. However, their work is not done. We must continue to address all these health disparities. You can read the entire article as well as the editorial by Janelle Scott in the February 2023 edition of the RadioGraphics Journal. Thank you for joining us.